The next speaker up in and again, this is a continuing educational session, is Dr. Georges Benjamin. And Georges has been part of the society and the journal from day one, which goes way back in time, a great supporter. I think most people on the call know who he is. He's the director of the American American Public Health Association. And he's one of those people that really combines clinical background with public health and has just been a great contributor to the area of disaster medicine. Before I turn it over to him, I did want to make one comment on disaster medicine. And when I use that term, I use it in a very holistic sense to include all of the disciplines and health professions that are involved in the work that we do. And we're looking at medicine holistically to include that whole system of healthcare and public health that is provided to our citizenry. And with that, Georges, I'd like to turn the microphone over to you.
Hopefully everyone can see that and hear me.
I can hear you and see it.
Perfect. So let me just say, obviously, the thing we're talking about today is climate change, and obviously climate change has a significant impact on a range of human health factors. I'm going to focus today on the issue of extreme heat, mostly because that's one of the areas in which most of us in emergency medicine spend a fair amount of time thinking about. Obviously every summer we're having longer and more prolonged heat waves. They certainly cause such things as drought and fires and things like that. But I want to talk about one public health intervention that I think that can make a big difference in our lives if we adopt it. And recognizing that the heat, at least from a clinical perspective, has significant impact on people. One of the things that often isn't recognized, and we in the emergency medicine world recognize it, is that one day of a very hot day usually isn't a big deal. Obviously the person that goes out and decides to run on a very hot day is going to be in trouble. But from a population perspective, it's usually on day 3 or day 4 when you start seeing large numbers of people who are presenting into hospital emergency departments or into health systems because they have significant impact from the heat. We often talk about the urban heat effect that occurs in urban settings in particular, which is what I want to focus my attention on today. We also know that this climate burden is not shared equally, that climate sensitive populations, which have limited resources to be able to adapt to climate change because of extremes of age or lower income, particularly in some minority communities, this remains a real challenge. And at the end of the day, this vulnerability relies a lot on community resilience. And I know you've had a couple of people to kind of talk a bit about community resilience through a couple of lenses today. And they think there are societal factors that one can do to impact that resilience. We know that those societal factors, obviously your zip code makes a big difference about your health. So it determines a whole range of factors: schools, jobs, healthcare access, transportation. But the built environment is one that's a really big one that people need to pay a lot more attention to. We know that built environment influences the temperature, that dark urban surfaces absorb rather than deflect most of the sun's heat. It creates hot cities and also increases air pollution. We also know that particularly in many of our urban settings, there's a lack of vegetation and trees to absorb heat, reduce pollution, and provide shade. And in many of these communities, as those communities have not been kept up, you have less trees. Many places will go in and pave over the green space, either because they want more parking lots or because they simply don't want to do the upkeep on those communities. And we know that these dark surfaces in the urban settings can make these communities as much as 9 degrees warmer on average. And of course, it's aggravated in low-income communities because of the less vegetation and the fact that they tend to have more dark surfaces. This is just an example of how these cities are getting hotter, particularly in low-income communities. So this is an example in the Richmond area, where the lower income community is the community called Oak Grove. Also some place called the Fan District, where temperature can be much higher than in this community, Windsor's Farms, which is not that far away. But you can see there's a big difference in temperature between as much as 10, 12 degrees difference between these two communities in Lower Virginia. Baltimore City in 2018, as an example, this was a day when the heat index went up to 103 degrees Fahrenheit. On that particular day, the emergency medical services was quite active. The rate of heat stroke more than doubled. The presentations for chronic obstructive pulmonary disease went up over 70%. Cardiac arrest rose over 80%. And people presenting with hypertension more than double. These are emergency medicine calls would actually picked up patients and either took care of them on the site or took them to hospital emergency departments. And we also saw other corollaries around psychiatric disorders, substance abuse, and dehydration, of course, spiked on this particular hot day. Looking at visits for Medicaid patients in the community went up higher in areas that were lower income than some of the cooler areas of the city, which were higher income. And in those communities, the low-income patients in these hotspots had more doctor visits for things like asthma, COPD, and heart disease. Whether or not they went to the emergency system or not, they presented in primary care systems in significant ways. And this is, again, an example of Baltimore City, which shows the same predilection that we saw in Lower Virginia, where the higher income community, which is this community up here at the top, where income is better, was much cooler than the lower income communities. And this is the communities in West Baltimore, around the Inner Harbor, west of the University of Maryland Medical System, as an example. And this just circles the higher income community versus the where they were much lower temperature in that higher income community compared to the lower income community. And again, the fact that there are less trees, more impervious surfaces, ultimate result, this is a logic model which basically points out the fact that in those communities, more death and illness occurred because of the temperature gradient that you see in there. And so I often talk about a heat dome within the heat dome, recognizing that you have this urban island effect within urban settings. And just to, quite simply, the fact that a dark roof is much more likely to absorb the heat, a light roof is much more likely to reflect the heat. It's also important to know that cities can cut their carbon dioxide equivalent emissions by 10 to 15% by increasing reflectivity of these roofs, and not just the roofs, but the streets and parking lots as well. Also, you reducing fossil fuel use, using solar panels, replacing the dirty grid electricity by and not using as much fossil fuels is going to be very important in these communities. So smart surfaces are surfaces that help better manage the sun and the rain. Things like reflective roofs, putting green roofs. A lot of people are putting roof gardens on their tops of their buildings, particularly some of the taller buildings, putting porous pavements in place, which allows you to better manage the water runoff in these communities. And obviously planting more trees and doing a combined solutions where you're working with solar on the roofs and strengthening the roads again, so they're more porous and that they're light in nature, so that they reflect the heat versus absorb the heat. And this is just another example. This is a bird's eye view of a city, and you can just again see just visually the difference in a dark roof versus a light roof, and recognizing that you can make a big difference in the temperature gradient in these urban settings. And then in closure, you know, by putting these things together in a comprehensive way, we ultimately can reduce these real situations where we have people with heat injury in communities, and hopefully unload some of the emergency medicine burden that we see, quite frankly, each and every year in our communities. Is a way that we might want to go. So with that, I'll stop. And I know we have another speaker, and then we will turn that over to the Q&A, I guess, at the end of the presentations.